Dr. Jairam Prasad, are you with us? Kanna sir, good evening, sir.
Hello.
Good evening, sir. Dr. Kanakvel here, sir. Good evening, sir. Thank you for joining, sir.
Good evening, sir.
Good evening, sir. Good evening. Sir, we'll start in a minute, sir. Just bear with me, sir.
Okay, sir. Okay.
Kanna sir, good evening, sir.
Yeah, good evening. Good evening.
I think we have Pai sir already joined. Sir, I think we will start, sir, as we are already 1 minute past 2. Friends, we have the lesson memo thing to share the yet another PG clinics for this evening. This is our 221st session, and we have close to 446 cases earlier discussed is available in the PG Clinics YouTube channel for your information. We have two important exam cases. One is the portal hypertension by Dr. Abhinand Mohan, kindly contributed by Professor Jayalal, Government Kanyakumari Medical College. The second case is by Dr. Jairam Prasad, case of varicose veins, Madurai Medical College, Madurai. The examiners for the evening, Professor Srinivas Pai sir from SDM Medical College, Dharwad, Professor Jawahar Krishnaswamy sir, Professor Gabriel Rodriguez, now have moved to Aster DM Health, Professor Manjunath sir, and Professor Ankur Maheshwari is from GMC Indore. So, friends, we have two venous cases this time. So, it's been quite some time we discussed case of portal hypertension. So, we are having portal hypertension and varicose vein. So, Jairam Prasad, can you try sharing your PowerPoint? Are you here, Dr. Jairam Prasad?
Yes, sir. Okay, sir.
Yes. You know the routines. Faculty have been here. As a quick reminder, the candidate will be able to run through the history part of it without interruption. At the end of the history, they will sum up the history, and the faculty can revisit slides one after the other from the first slide again. Same way, they'll be allowed non-stop till the end of the diagnosis made, and then they can revisit the slide again from the general examination onwards. So they will again have at the end of it slide by slide comments, questions after that is over. Then we move on to the investigations and the management part of it. Little bit about operative surgery and complication management as well. So with that few words, I hand over the day's proceeding to the faculty, and I wish both the postgraduates a very good luck for today's PG clinics. So Dr. Jairam Prasad, I request the PGs to introduce themselves, their head of the units and the head of the department, and start their presentation. Good luck to you, friends. Jairam, you can share your PPT, ma. Are you ready?
Okay, sir.
Do you have any challenge in doing it?
Yes, sir.
Okay, so I will ask Abhi to go ahead first. You can present second. Abhinandan?
Yes, sir.
Abhi, you please share your PPT and start your presentation. I think Jairam has some challenge. I think he has got the presentation. Just a moment, ma. Just a moment.
Oh.
Can you open the PPT, ma? Give me a moment, Abhi. I think Jairam is
Okay.
trying to do something. Jairam, I request you to unshare for a moment. Because you have some challenges. Please start these challenges. So, Abhinandan, can you try sharing your PowerPoint and start your presentation, please?
Okay, sir.
Yeah, good luck to you, Abhinandan. Jairam, you can set your systems in place and you can present as a second case. Good luck to you.
Thank you, sir.
Yes, ma'am. Abhi, please start your presentation.
Sir, my screen is shared, sir, or
Ma'am, we are able to see your video.
my screen is now. You can see my screen, sir.
Not yet, not yet.
Sir. Sir, now, sir.
Yeah, we are just getting your screen on now. Yes,
Oh.
make it full screen and you are fine to go. Good luck.
Okay, sir. Thank you, sir. Good evening, sir. My name is Dr. Abhinav Mohan.
रेफरेंस का वेट करे मेरी इंटरनल फाइल लेके बैठी हुई है
So shall I start, sir?
Yeah, go ahead, go ahead.
Good evening, all, sir. My name is Dr. Abhinav Mohan. I'm a third year student of my professor of department is sir. My unit chief is my assistant ma'am. My assistant professor is government system. So I'll proceed with that case. 53-year-old male patient of low social distance and a resident of Kanyakumari presented chief complaints of blood problems for past 4 days. By 4 days back, history of muscle patient patient so and a sudden particles 3 days back.
There's an audio problem, I think, Abhinandan.
We can't hear you.
Sort out your audio.
Abhi, you try speaking now. You remove your headset, Abhi, if you are wearing one. Abhinandan, unmute yourself.
Sir, am I audible, sir, now?
Yeah.
Perfect. Please go ahead.
Sir, I'll start once more, sir.
No, it's okay. Start from here.
Patient had a episode of blood incompetence, sudden onset, projectile, approximately 2 mm with containing toxic particles 3 days back. It was not associated with food intake or alcohol intake, not associated with retching or coughing prior to vomiting. There is no history of abdominal prior to vomiting. History patient also has history of vaginal progressive distension of abdomen with history of middle and for the past 3 months. There is no history of breathlessness or history of patient performance.
Oh.
History of and also history of jaundice for past 3 months, also with pruritus or pale stools. It is also noticed with fever, malaise, or any other high risk behavior. The history of black stuff.
The moderator,
Yes, sir.
Can we interrupt here at this point?
Yes, sir. Yes.
Yeah, because again going back, So, what would be the question? The color of the urine, or you will go for pruritus in the jaundice?
I didn't get you, sir. Once more.
You want to ask the color of the urine first when a patient comes with the jaundice, or you'll directly ask for pruritus or pale color stools?
Urine.
See,
Sir,
whenever a person comes with jaundice, the first question you should ask him is the color of the urine,
Yes, sir.
rather than the color of the stools and the itching history, pruritus. It's not pruritus, it is pruritus.
Pruritus.
P-U-S. Okay, that's a spelling
Yeah.
mistake. All right, but color of urine should be the first one in your inquiry to the patient. Okay, why we
Okay.
do that is what's the purpose of asking for pruritus or pale color stools?
Sir,
Is
pruritus
your
and pale color.
purpose? Huh?
Sir, pruritus and pale color.
You're not audible, sir. You're not audible. Yeah, I think you should
Sir.
come closer. Yeah.
Sir, am I audible now, sir?
Yes.
Yes.
Your problem is distance, so that's a distance. Okay. Now that you
Okay.
established the distance, now you speak.
Sir, pruritus and pale color stools indicate that patient is having obstructive jaundice.
Yeah, but don't you want to rule the other types of jaundice? Hemolytic jaundice?
Now, first establish whether there's jaundice and then try to quantify what kind of jaundice it is. Okay.
Yeah.
Okay, sir.
No, you have to ask for history of urine first. The color of the urine, rather. Why? If the color of the urine is normal and there is a jaundice, then the prehepatic jaundice is out.
Okay, sir.
Okay, all that's far-fetched.
Okay, sir.
That is the way to go about it. The first question in a history in a patient who tells you about his jaundice is about the color of the urine.
Okay, sir.
Once the color is normal, it is hemolytic jaundice or acholuric jaundice. Okay.
Okay, sir.
The moment that urine is dark color, then you have a problem. Either it is hepatocellular or it is this one, obstructive jaundice.
Obstructive jaundice.
So, moment pruritus is there and pale color stool is there, it's not a guarantee it is obstructive jaundice, but more likely. Okay.
Yes, sir.
Thank you.
Sir, shall I proceed, sir?
Yes, please.
There is history of passage of black stars for past 1 week. There is 3 to 4 episodes, and it's more expensive. Patient has history of alcohol intake for past 25 years. Daily intake of nearly 300 ml. Last intake was 2 months back. There is no history of any abdominal lump, weight loss, or loss of appetite. There is no history of rectal bleeding from lungs or hematuria. There is no history of prolonged bleeding of the trauma. There is no history of episode of any sensorium or diarrhea. There is no history of blood transfusion. There is no history of indirect vein programs. Past history: patient is known hypertensive on regular medication, and there is no other comorbidities like diabetes, mellitus, or thyroid disorders. No history of any surgeries in the past. Personal history: patient is a patient mixed diet. He's sleep pattern. There is no history of any constipation or those things. Bladder. There's no other addiction. Summary: 53-year-old male patient, chronic alcoholic. 1 episode of symptoms, 3 to 4 episodes of history of long distance from Peter and Mom, altered sleep pattern with history of jaundice. Probably upper GI bleed resulting from portal hypertension. Probably very severe.
Okay. Sir, please, Professor Harirao. Professor Harirao, I think you raised your hand. Okay.
No, nothing, sir. It's stuck. No problem.
Okay. Let's go to your first slide.
Next one, sir.
History of blood and vomitus 3-4 days back. That was the first episode. Nothing before that.
Nothing before that. Actually,
we can't hear you.
Sir, there's actually distance from abdomen.
Doctor, no, we can't hear you at all. Try and get hook on to a microphone if possible. Then.
Sir, are you audible?
Yeah, it's moving up. It's coming in waveforms. The volume is moving up and down.
Sir, just 1 minute, sir.
Dr. Abhi, I think if you have a problem, you should change your laptop or something. I can allow you to as a second case. You please log out if you have a challenge,
Sir, 1 minute,
because
sir.
it's going to be difficult for another 45 minutes to go ahead with that.
Because it'll be start, stop, you know.
Yes, Abhi, I would request you to please.
Sir.
We'll start off from
Then
where
you
you let
can-
the history, Abhi. Okay, we'll go quickly through. You log out and get the other guy in, Varicose veins guy in.
Sir, I will log in from another computer, sir.
Okay, just log in.
Your audio system is an issue.
Okay,
Log
sir.
in.
Yeah, log out and log in, best. You will finish the next case to save time, sir. Kanagvel, sir.
Yes, sir. Yes, sir. Definitely.
Yeah. Dr. Gabriel is here or he's logged in?
Sir, he is operating, I guess, sir. He should be joining anytime, sir.
Okay.
Dr. Jairam Prasad. Dr. Jairam Prasad. Give me a moment, sir. I think that chap is thinking aloud that he is going to be the second.
So, Srinivas sir.
Yes,
Srinivas
sir.
Pai, sir.
Yes,
Good
sir.
evening, sir.
Good evening, sir.
Sir, you are doing wonderful job, sir. Preparation
What
is
to know?
going very.
I know. We have a lot of things, new things, which
Yes,
sir,
yes.
Kanagvel, sir, we are having the conference, state conference.
Yes.
So-
Give me a moment, sir. Give me a moment.
Yeah, we are having the state conference right now in SDM, our Karnataka state conference. So this is a good. I accepted
Dr.
this. to
Abhinand,
get
you
away
have
from-
joined with, sorry, sir. Dr. Abhinand is here. You have joined with the new system, ma?
Yes, sir. 1 minute, sir.
I think now your audio is much, much better.
Sir. Now it is
Or
okay.
you can use the other system for the laptop if you want to use the PowerPoint if you do not have in the system.
Sir, I have, I have joined. PowerPoint is there in the system,
Okay,
sir.
please share the PPT.
Sir, now you can't see my PPT, sir. I have actually shared it.
No, not yet.
One more thing, sir. 1 minute.
I request all of you to just upgrade your most recent version of the PPT. Sorry, I'm PPT as well as the Zoom.
Sir, now, sir.
Yes,
Yeah,
very good.
Yeah,
Good
we are
luck
good
to
to
you.
go. Yeah.
Proceed.
So now I am audible, sir.
Yes, Dr. Abhinand, please go ahead.
Sir, should I start from the beginning, sir?
No, go on.
You start from the beginning. It's all right. We have to discuss some things here. So, what my suggestion is to go say as a postgraduate to say the word hematemesis straight away,
Yes, sir.
rather than say blood in the vomitus.
Yes,
Because
sir.
if you say blood in the vomitus, you will invite one more question. That is
Yes,
whether it is really hematemesis or whether it's hemoptysis. Beginning, it's all right. We have to discuss. You will have to differentiate between hematemesis and hemoptysis.
Yes, sir.
So by telling hematemesis, you are committed that it is hematemesis. So when we ask you why it is hematemesis, then you can give answer 1, 2, 3 like that. Differences. And also next slide, please. So you should talk about Malina also.
Yes, sir. Yes, sir. I have mentioned, sir. Next slide I have mentioned actually.
Yeah, and go to the next slide. So is there a history of Malina? You have to tell it is called Malina, the back tarry stools.
Yes, sir.
Okay, straight away interpret and tell it. You'll save time.
Yes, sir.
Instead of telling black tarry stools, we'll ask you what that is. So
yes,
there is a Malina, definitely. That means the amount of bleeding is more than 100 ml.
Yes, sir.
Correct?
Yes, sir.
There is both a hematemesis and this a Malina. So
yes,
why does the Malina occur?
Malina occurs due to oxidation of blood. So actually, Malina occurs if the bleeding is above the ligament of treats. If actually after the blood formed before the ligament of treats, it gets oxidized by intestinal and intestinal bacteria. It forms resulting in Malina, sir. Black tarry.
Somebody has said, can we use medical terms in presentation? The answer is in MBBS. All this comes. Whereas in masters in surgery, you can use. You already have a degree. So you
Yes, sir.
should not be asked what is melena, hematemesis and that. Whereas in MBBS, when somebody has asked, right? So I'm clarifying that in the chat. So can we use medical terms in presenting complaints? The answer is yes, we can. And the reason I'll tell you is called as transcribing the patient's language, medical transcription, transcribing. Okay, we cannot use like medial, lateral and all those, but if there is a symptom and there is a clear-cut name for it, you have to transcribe it into medical English. Patient will tell it that patient's own words, no, is for MBBS students who are not knowing what is hematemesis, who is not knowing melena. For those vomiting of blood, then you'll ask the MBBS student, what is it? Then you'll ask the knowledge, a degree of knowledge they understand. An MS student already has an MBBS degree. So he need not be assessed on the terminology again. He will already be knowing. He has got an MBBS degree based on that. So to ask him to tell in not in technical words, it's better to save time, because MS exam is about analysis more than the terminologies. So somebody asked that, is that very clear? I, as an medical educator, for a postgraduate exam, to use medical terms is correct. Fine. So, am I audible, Abhinandan?
Yes, sir. Yes, sir. You are
Yeah.
audible, sir.
Why do you get melena? Why do you get the melena? What's the reason? What you said above the ligament treats is wrong. Okay, melena can come anywhere
Happen up to
the
cecum, sir.
ileum.
It can happen up to cecum, sir.
What it is no, about the ileum, because if the bleeding is significant, then the patient will have won't have melena. He'll have hematochezia, even if it's
Hematochezia,
upper GI bleed. So this bleeding must be less than 300 ml, but more than 60 ml. Less than 60
yes,
ml, you'll get microscopic bleeding. You will not make it. Occult bleeding it is.
Yes, sir.
Above 300 ml, patient will have blood in the stools. You'll actually have blood in the stools. It should be in the narrow range of 60 to 300.
Yes,
narrow, high enough to not to be occult, and low enough not to have blood in the stools. Understood?
Yes,
so,
sir.
and it's high up because there is a distance in which the bacteria should act. Clear?
Yes, sir.
Right. Go on.
So shall I proceed to
History. That last one. Not this, buddy. The diagnosis.
that diagnosis? Okay, sir.
Yeah. Your analysis. Yeah. Okay. Here you can say it's looking like an upper GI bleed. 53-year-old chronic alcoholic looking like an upper GI bleed. Now, why do I tell you upper GI bleed is? Melena may occur in lower GI bleed also, but hematemesis occurs only in upper GI bleed.
Yes, sir.
Lower GI bleed will never cause hematemesis. But upper GI bleed and lower GI bleed can cause melena. Okay?
Yes, sir.
Fine.
Oh, yes, sir.
So you can say 53-year-old alcoholic with upper gastrointestinal bleeding. In liver failure. You can say that liver failure. This is a interpretation, no? What you're supposed to put in the summary.
Yes, sir.
Yeah, you can go on the front foot and make a commitment. Okay, you can say this is a 53-year-old with the upper GI bleed with liver failure or decompensated liver disease. Why you're saying it's upper GI bleed is there is both hematemesis and melena. Correct. If there was only melena, then no, you have this side, that side. Okay. Why you're saying decompensated liver diseases, jaundice, and couple of other signs of liver failure are there. Okay, sleep pattern and like pedal edema is a sign. No, patient will not. So signs you should not ask the patient for. Okay, signs you should not tell. No. Right. Next. Yeah. Go on to the history. Clinical examination.
General examination. Patient was examined in a well-lit room after due consent. Patient was conscious, oriented, and cooperative. Moderately built and nourished. Afebrile. Pulse rate is 88 in right radial artery. Regular in rhythm and volume. Respiratory rate is 22 cycles regular. Abdominal thoracic. BP was 110/70 in right brachial artery in supine position. There is no distended vein. Pallor was absent. Ictus is present in the ictus is present. Bilateral pitting pedal edema is present. There is no lymphadenopathy, cyanosis, clubbing. Bilateral gynecomastia is present. No other signs of liver cell failure. Examination of skull and spine normal. Per abdomen examination, patient was examined in supine position after adequate exposure. Inspection, abdomen was distended, flanks full, umbilicus placed slightly inferiorly in the midline. There is no distended veins, scars, sinuses, visible pulsations.
Somebody can mute them, please, sir. Moderator.
Please.
Yeah. Hello. You can unmute yourself, Abhinand. Abhianand. Unmute yourself. Unmute yourself.
Sir, am I audible, sir, now?
Yes, yes, you're audible.
Sir, I will start from here, sir. Inspection, I will start, sir, once more.
Yeah.
Patient was examined in supine position with adequate exposure. Abdomen was distended, flanks full, umbilicus placed slightly inferiorly in the midline. There is no distended veins, scar, sinuses, visible pulsations, visible peristalsis. Bilateral hernial orifice is normal. Bilateral renal angle normal. External genitalia normal. Palpation, inspectory findings confirmed. No local rise of temperature, tenderness or guarding or rigidity. Spleen was palpable 7 centimeters between left hypochondrium and umbilicus, firm in consistency, even in surface, with palpable notch, moves up with respiration. Finger cannot be insinuated between the costal margin. Liver cannot be palpated, sir. Percussion, fluid thrill present, shifting dullness present. Upper border liver dullness felt at 16 intercostal space. Lower border could not be elicited. Dull note over the trough spaces. Dullness present in the flanks, bilateral flanks and pelvis.
Why did you check for dullness in the trough space? What's the reason? You go back to your palpation, sir. Go back to your palpation.
Palpation.
See, now there are two schools of thought in surgical teaching. School of thought number one, traditional, says that any mass which is palpable, you have to describe it as a mass. You have to say there is a mass whose upper border is not felt, 7 centimeters below the 7 centimeters below what you're between the left hypochondrium and umbilicus. This is a wrong definition of describing a spleen. Okay, there should be a point of reference, anatomical reference.
Okay,
it's
sir.
not the right hypochondrium; it is the left costal margin.
Left costal margin.
Where in the left costal margin you can use any anatomical point. You can normally we use the mid clavicular line.
Right.
Mid clavicular line. So you have to say the mass superior border not felt.
Superior border. Okay.
First step is there is a mass palpable. Second step is all the borders are not felt. Instead of that, you can say superior border not felt.
Yes,
therefore, inferior border is 7 centimeters from the left subcostal margin in the mid clavicular line.
Yes, sir.
Third thing, the mass moves with respiration.
Yes, sir.
One cannot insinuate your fingers between the mass and the costal margins. The mass is not bimanually palpable because for the left side, one more mass comes in that region. So bimanually palpability has to come. Okay?
Yes. Yes, sir.
Then once you've anatomically ascertained the mass, then go for the consistency, surface, and other things.
Yes, sir.
Fine. So therefore, the mass is the spleen. This is the way you have to present a splenic mass.
One more thing, Dr. Abhinand. Well,
Yes, sir.
already we have committed it as splenomegaly, isn't it?
Yes, yes, sir.
No need to mention it, that finger cannot be insinuated between the costal margin. No
Yes,
need
sir.
to mention that there is a palpable notch.
Yeah.
That
Yes,
means
sir.
it is confirmed. Already we have committed. That is splenomegaly.
Yes, sir.
We understand that there is a palpable splenic notch and finger cannot be insinuated, isn't it? Moves
Yes,
with
sir.
respiration. That is everything understood. If you are not committing
Yes,
it as splenomegaly, then you have to describe everything and at the end you can tell that.
Yes,
The
sir.
findings are going in favor of splenomegaly like that.
Yes, sir.
Isn't
Yeah.
it?
Even
Yes,
when
sir.
you commit to
No need to mention it.
Yes, sir.
see, even when you commit to splenomegaly, right? There is a splenomegaly 7 centimeters from the left subcostal margin in the mid-clavicular line. Like that you have to tell.
Okay, sir.
Yeah, but if you are presenting like a mass, exactly how I told it. So
Yes, sir.
I am telling you there are two schools of thought. One is to present it like a mass and
Yes,
then
sir.
tell that it's a spleen conclusion.
Yes,
Or
sir.
you can present the conclusion first with all the findings and the rest of is superfluous because you have
Yes, sir.
come to a conclusion based on your findings. You need not tell it what Dr. Kotnawar has said. Okay.
Yes, sir.
Right. Next. So now comes dull note over the top space. Okay.
Yes.
Now these physicians, right, they try to look for splenomegaly even when the spleen is not palpable. So at how much, how many times the spleen should be enlarged for you to be able to palpate it?
Actually 3 to 4 times, sir.
Yeah, 3 times it is. 3 times.
3 times,
4 times better. 3 times is okay. 3 times is a reasonable figure.
Yes, sir.
So the spleen is enlarged even before it is palpable, correct?
Yes, sir.
So they percuss the top space, which is dull. When the
Yes, sir.
spleen is not palpable, this test is used. It is
Yes,
called
sir.
as Cassell's test.
Yes, sir.
Cassell's test is the theory is like this. When the person is when the person is in inspiration, the stomach will come in that top space. Okay.
Yes, sir.
When we take a deep breath, air will enter the stomach and will sit in the top space. Correct? Step 1.
Yes.
To percuss, you should get a resonant note because there is a stomach sitting there in the top space.
Yes, sir.
Right? Now,
Yes, sir.
when you leave the breath out and you percuss, this becomes dull. It becomes dull again because there is a spleen there. Correct?
Yes, sir. Yes, sir.
Yeah. But if the spleen is enlarged, correct?
Yes, sir.
When it takes a deep breath, when you percuss, there's still a dull note. First is normal. When a person takes an inspiration, the stomach is filled with gas.
Yeah. Yes, sir.
When you put a percussion, there
Yes,
is a resonance. When the
Yes, sir.
person takes his breath out, there is dullness because there is a spleen there. Fine.
Yes, sir.
Yeah. But on inspiration, you still get a dull note. That means the stomach has cannot distend there because there's a huge spleen there. Fine.
Yes, sir. Yes, sir.
It's called as Cassell's sign. It is the most useless clinical examination described to mankind. This is all the physicians are fond of it. It's very confusing. It's a sign and a test to be condemned. Okay.
Okay, sir. Okay,
and
sir.
when you are palpating the spleen over there already, why you want to dull note the top space?
Okay, sir.
You have to tell the splenic spleen. You're already committed to splenomegaly. That's your mistake.
Yes.
If there
Yes,
is a mass, you have to tell the mass dullness is continuous with the dullness which is in the top space.
Yes, sir.
It's correct. When you already have a palpable spleen, it's not necessary to do the top space percussion.
Yes, sir.
It's a useless test actually. The book only gives it as useless. Okay.
Yes, sir.
Fine.
Dr. Abhinand, you are told
Yes,
fluid thrill present.
Yes, sir.
Can you elicit shifting dullness when already fluid thrill is present on percussion?
Yes. Yes, sir.
See, these signs depend upon the amount of fluid in the peritoneal cavity, isn't it?
Yes, sir.
The more the amount, the
More-
increasing order, like podal sign first, then bilateral or should dullness will be present, then comes shifting dullness, then come last with the fluid thrill, isn't it?
Yes, sir.
By the time fluid thrill is present, you need not mention this. It is not possible to elicit shifting dullness because there is so much amount of fluid in the peritoneal cavity.
Okay, sir.
It is blunder to mention that shifting dullness present in the presence of fluid thrill.
Okay, sir.
And what is the method of palpation of spleen in presence of free fluid? Like fluid thrill, presence of fluid thrill.
Deep
What is
palpation.
spleen?
Dipping palpation, sir.
Yeah, dipping method,
It will
isn't
be
it?
dipping method of palpation.
Not a routine palpation method, isn't it?
Yes, sir.
Okay. Please go ahead.
Dr. Abhinandan,
Yes, sir.
you mentioned there were no signs of liver failure present
Yes, sir.
in your general examination.
Yes, sir.
Don't you think it's a paradox when at the one end you are saying fluid thrill is present, which is actually a sign of severe ascites and severe liver failure, and you couldn't find any other sign of liver failure?
Actually, I couldn't find, sir. Actually, I searched for it. He has only bilateral gynecomastia, to be precise, sir. There was no other signs of liver failure, sir.
What are the other signs of liver failure which you see in a case of
Sir,
such a case?
alopecia areata, jaundice, parietal swelling, spider nevi,
What
palmar
spider
erythema.
nevi?
Spider nevi more than 5, sir.
Okay. Where do you look for them?
In the anterior abdominal wall, chest.
What is the cause of spider nevi?
So it is due to dilation of it is due to dilation of arterioles, muscles, muscles pus. Sir, I'm not aware, sir.
Okay. Which hormone influence? I will give you a hint.
Estrogen, sir. Relative estrogen excess leads to spider nevi, sir.
So your patient has gynecomastia, but your patient doesn't have a spider nevi.
Yes, sir.
Okay, fine. Were there any signs of testicular atrophy or such?
No, sir. External genital is normal, sir.
Okay.
Dr. Abhinand, in
Yes, sir.
infection, one more thing you have mentioned that bilateral hernial orifices normal.
Yes, sir.
So what are those two bilateral hernial orifices you look for?
Sir, umbilical hernia will be present, sir. Then
Umbilicus is a single entity, isn't it?
Yes, sir.
Better in place of that, don't mention like bilateral hernial orifice is normal. Say all hernial orifices intact, you can say. Then we understand that even you have looked for umbilical hernia also. Because umbilical hernia is the one which is more commonly seen in patients with ascites. Isn't it?
Yes, sir.
Yeah. So don't mention like that bilateral hernial orifices. We mean that we are looking for only inguinal hernia, not umbilical hernia.
Yes,
so better is to mention all hernial orifices intact.
Yes, sir.
Okay.
So shall I proceed, sir?
Yeah, sure.
Auscultation, bowel sounds present, no venous sound. Paral examination, melena present. Other systems examination, normal.
Just a minute. Describe your perical examination, your methodology.
Sir, with the patient in the Sims position, we'll insert the index finger.
So what I want to know is PR is of two inspection and then PR.
Yes,
so
sir.
did you do a proctoscopy or not?
Yes, we'll do proctoscopy, sir.
Did you do in this patient?
Yes, sir. We have done, sir. Proctoscopy.
What is the findings? You have to be very clear with this.
Sir, actually, proctoscopy, there is no rectal varices or nor hemorrhoids.
Exactly. You have to tell that you have done an inspection. There's no fissure, fistulous opening.
Yes.
And then you have to do the proctoscopy. After that, then say there is no rectal varices. You have to commit to that.
Yes, sir. Okay, sir.
Right? You have to mention both positive as well as negative.
Yes, sir.
In a portal hypertension case. Means
Yes,
that's
sir.
what we are heading to. So whenever there's a decompensated liver disease, always do a proctoscopy.
Okay, sir.
Whether or rectal varices is there or not, it's not important. It's
Yes,
whether
sir.
you are looked for it is very important. Okay.
Yes, sir.
Thank you. Thank you.
Other system examinations normal. Diagnosis: a 53-year-old male patient presented with one episode of hematemesis, ascites, bilateral pedal edema, and splenomegaly. Probably hematemesis due to variceal bleeding. Etiology: alcoholic liver disease with cirrhosis.
Cirrhosis is a pathological diagnosis, no? Can you give a diagnosis of cirrhosis?
Cirrhosis. Sir,
this cannot be a diagnosis, no? It's pathological.
Okay, sir.
What you can give? What is a better diagnosis?
The patient has got Abhinand.
Yes, sir.
Patient all the three classical components, isn't it?
Yes,
that
sir.
is ascites, hematemesis is there.
Yes, and splenomegaly.
So can you commit it as a portal hypertension? You are in diagnosis.
Yes, sir. Portal hypertension.
Isn't it? Directly you can commit it in the diagnosis. A case for a 53-year-old male patient with portal hypertension. All the three features.
Yes, sir.
Due to alcoholic liver disease with decompensation liver disease. You can mention like that.
Probably
Okay,
due to cirrhosis.
Probably
Yeah.
due to cirrhosis. Okay.
But so this diagnosis is not acceptable. Okay.
Okay, sir.
Okay. What's the fourth component? Three components. What's the fourth which is missing? One is ascites. Second one is splenomegaly. Third one is hematemesis. There is a fourth component for portal hypertension. That's why all the four need not be there. You can have two of the four to have a diagnosis. You can have ascites. You can have a combination of 2 out of 4.
Sir, I'm not aware.
Caput medusae, no?
Caput medusae. Caput medusae, yes, sir.
Is it there? Dilated
No,
vein?
sir. Caput medusae is not there, sir.
Yeah. Caput medusae you get in which type of portal hypertension? Only caput medusae you get in which type of portal hypertension? How do you classify the portal hypertension?
Prehepatic, hepatic, posthepatic.
Okay. Posthepatic is also called as?
Veno-occlusive disorder, sir. But
Yeah.
Budd-Chiari syndrome.
Yeah. In that, what type of dilated veins you get in Budd-Chiari syndrome? In a Budd-Chiari syndrome is due to hepatic vein occlusion, no, or IVC, IVC
Yes,
ring, all those. There's a whole set of things. So
Yes, sir.
that is post-hepatic this one, post-hepatic portal hypertension. There you
Yes,
get
sir.
dilated veins on the flanks also. In a portal
Yes.
hypertension due to a post-hepatic cause like a Budd-Chiari syndrome, you will get a dilated veins in the flank along with umbilical veins. Okay.
Okay, sir.
Whereas in other portal hypertension, you get only dilated or on the umbilical veins.
Umbilicus.
What is the prehepatic also called as prehepatic?
Hematology.
Prehepatic jaundice, no. Prehepatic portal hypertension.
Depression. Sir, not aware, sir.
What is EHPO? Have you heard of this EHPO?
Extrahepatic portal vein occlusion.
Yeah. What do you get in that? Where do you get that?
Sir, it is mostly due to venous thrombus or congenital webs, mostly seen in younger and children.
That's a Budd-Chiari syndrome, no? Prehepatic is which one? Also congenital something. Portal vein.
Atresia, sir.
Cavernoma. Portal vein cavernoma. It's called sinistral hypertension. Left-sided.
Left side.
Think of the causes of the left side. And this is hepatic causes of portal hypertension. Correct?
Yes. Yes, sir.
Go on.
Vinand, if you get the veins in the abdominal wall,
yes, sir.
In which position you examine the patient?
Sir, standing position, sir.
And where you will examine for the veins?
Sir, for portal hypertension, we will examine the anterior side. For we are looking IVC obstruction. We look in the flanks and in the paraspinal region, sir.
So in the abdominal wall, in which portion you will see for the dilated veins? Because you have to check the direction of the flow.
Yes,
By
sir.
the flow, you can tell whether
it's
obstruction or obstruction.
Sir, in portal hypertension, flow will be away from the umbilicus, sir. In IVC obstruction, it will be from in the cephalad direction from below upwards, sir.
Right. So where you will examine for the veins?
Sir, in IVC obstruction, in the flanks and in the paraspinal region, sir.
You never know about whether it is IVC or portal. You get the patients having the veins distended on the abdominal wall. So in which part you will find the veins, whether it is because of portal hypertension or whether it is because of the IVC obstruction?
In portal hypertension, we will get around the umbilicus.
That. Upper abdomen or lower abdomen?
Upper abdomen, sir. Portal hypertension, upper abdomen.
No, you will always examine below the abdomen.
Okay, sir.
Okay, never upper abdomen. It is always below the umbilicus.
Yes, sir.
Below the umbilicus, the direction of the flow will change.
Yes, sir.
Okay. So in the case of the IVC obstruction, it will be from below up, while in the case of the portal obstruction, it will be up below.
Yes.
So,
yes, sir.
In the upper abdomen, it will be the same direction.
Yes, sir.
So always examine in the lower abdomen, not in the upper abdomen.
Yes,
And
sir.
then examine the back of the patient. If you
Yes,
find
sir.
the back of the patient, it is likely to be the IVC obstruction.
Obstruction, sir.
Would you like to tell us the liver span in this patient?
Sir, liver span could not be elicited, sir. The lower border could not be elicited due to continued dullness over the abdomen.
But you should have mentioned at least, because this is one of the most important thing you are going to tell in the case of portal hypertension. That is the liver span. It's a shrunken liver is there, or
Yes,
it's a
sir.
liver is there, or it's an enlarged liver is there.
Yes, sir.
Because ultimately, if you see for that, your treatment will change according to that.
Yes, sir.
How do you clinically differentiate whether it is the EHPVO or it is a hepatocellular or whether it is a post-hepatic? Clinical.
Clinic.
Yeah.
Sir, no, I'm not aware. Clinic.
Any difference in the age group?
Sir, EHPVO mostly pre-hepatic and pre-hepatic will be of younger age group, sir.
So in the younger age group, if you get that, it is likely to the EHPVO.
EHPVO.
Cirrhotic livers?
In middle age, sir.
Middle age. And the post-hepatic variety?
In the old age, sir. Venous thrombosis.
Not in the old age. Again, it's the same in the middle age. What are the usual causes of the Budd-Chiari syndrome?
Sir, venous thrombosis or congenital webs, sir.
Okay. So is it more common in males or females?
Sir, I'm not aware, sir.
The females taking the oral contraceptives.
Yes, sir.
They are likely to have the Budd-Chiari syndrome.
Yes, sir.
The liver function, what will happen in the three groups?
Yes, sir.
Liver status.
Sir, I didn't get the question, sir.
What will happen to the liver status in the case of EHPVO, in the cirrhotic and in the post-cirrhotic, in the post-hepatic?
Liver status. Sir, in cirrhotic, there will be
liver will be normal.
So in cirrhotic, there will be shrunken liver, sir.
What will happen in the EHPVO?
EHPVO, there will be the Budd-Chiari syndrome. There will be early stage. There will be enlarged congested liver. In late stages, the caudate lobe will be enlarged. The rest of the liver will be cirrhotic and small, sir. Shrunken, sir.
So in the case of the EHPVO, the liver will be normal.
Normal.
In the case of cirrhotic, it may be small span.
Yes.
If the Budd-Chiari is there, it will be enlarged liver or congested liver. Will be.
And just look earlier, sir, late stage.
In the patients with the portal hypertension.
Yes, sir.
When you are doing the proctoscopy in this patient, how will you differentiate whether it is the hemorrhoids or whether it is the rectal varices?
So while doing proctoscopy, the hemorrhoids will be pink in color, rectal varices will be blue in color. Actually, the rectal varices will be compressed by the proctoscope. The hemorrhoids will not be compressed by the proctoscope. It will be protruding into the lumen of the proctoscope. The hemorrhoids will be below the dentate line. Rectal varices will be above the dentate line. Sir.
Right. Now, why did you examine the skull in your patient? You said in the general examination, the skull was normal. Why is that? What you wanted to see in the skull of this patient?
Sir, yes.
Written somewhere, no?
Yes, sir, I wrote, sir.
In the general examination is written.
Yes, sir.
Hello,
I wanted to ask the same question actually at that time, but I thought this time was getting over. It should come in the end.
Oh, okay, sir.
See, because you know why it should come in the end is normally we examine the skull and long bones when we are thinking of a malignancy.
Yes, sir.
Malignancy like an RCC or other outside the system, CA breast or something, which is commonly prostate CA, lung cancer. These are the ones that go to the bone.
Yes, sir.
So while examining it, the beginning itself, we are thinking of a malignancy. That's what sir is asking. I don't know. You'll have to ask sir because his thought process may be different than what I am thinking.
Yes.
Now tell the differential diagnosis of a patient having the hematemesis with splenomegaly.
Sir, malaria.
Yes.
Why hematemesis?
Hematemesis.
Malaria, yeah, based on the findings or the history and the findings together? You made your conclusion, malaria.
Sir, if you are asking DD, sir, we can include malaria.
In this patient.
Not in this patient, sir, not in this patient. Because malaria, there will be fever, will be there, sir.
Why hematemesis will occur in a case of malaria?
Sir?
Why the hematemesis will occur in a case of malaria? The reason for that is taking the NSAIDs.
NSAIDs, yes, sir.
So there will be associated gastritis may be there because
Yes,
the
sir.
patient high fever, and
Yes,
that
sir.
is for the bleeding.
Yes, sir.
Tell other causes of this combination. Hematemesis with splenomegaly.
Sir, I'm not aware. Hematemesis, splenomegaly. Peptic. I'm not aware, sir.
Leukemia.
Yes, sir.
Can it occur?
Splenomegaly. Yes.
Splenomegaly in leukemia?
Yes, sir.
There's a huge splenomegaly is there.
Yes, sir.
If you are suspecting a patient having the leukemia, what other sign you will elicit in the general examination?
Leukemia.
Yeah.
Leukemia affects usually axial skeleton, no?
Sir.
Will you check for the bony tenderness?
Yes, sir. Yes, sir.
Will you look for the gums of the patient?
Yes, sir. Bleeding gums will be there, sir.
Hypertrophic gums. No?
Hypertrophic gums.
Okay, hypertrophic gums, sternal tenderness will be there.
Surgical causes where you get what we see in surgery, we'll get hematemesis and splenomegaly.
Surgical.
Pseudocyst of the pancreas.
Yes, sir.
Pseudocyst of the pancreas can cause varices, and
Yes, sir.
because portal vein thrombosis will occur in it. Splenomegaly also occur as a result of portal vein thrombosis. You get splenomegaly, as well as you get portal hypertension. Okay.
Yes. Yes, sir.
Anything that can cause portal vein thrombosis will cause splenomegaly. So any malignancy in the pancreas, body of the pancreas, any malignancy in the stomach, anything that can cause portal vein thrombosis can cause splenomegaly as well as hematemesis. Okay? Without having, right? But basic mechanism is portal hypertension only. Okay?
Okay, sir.
Yeah.
Patient of jaundice may have the hematemesis and splenomegaly.
Sir, can you repeat those, sir?
Like in your patient, the jaundice is there, na? History of jaundice.
Yes, jaundice. Yes, the jaundice is there, sir.
So now explain the reason for jaundice plus hematemesis plus splenomegaly.
The patient is going for liver cell failure, sir. That is why there is jaundice, sir.
Will jaundice be primary cause for that?
No, sir.
Having the portal hypertension?
No, sir. Patient is going for liver cell failure, sir. That is why jaundice is there.
Biliary cirrhosis?
Yes, sir.
What is biliary cirrhosis? You know biliary cirrhosis?
Yes, sir. And
if there is obstruction to the bile duct is there,
yes, sir.
Stricture, maybe because of stones, maybe because of malignancy.
Yes, sir.
The biliary cirrhosis, and ultimately the patient develops the portal hypertension.
Yes, sir.
Okay.
Yes, sir.
Right. So in this patient, if you are keeping this diagnosis, what is the cause of portal hypertension?
Sir, cirrhosis, sir. Alcoholic liver disease leading to cirrhosis, sir. Probably cirrhosis.
What is non-cirrhotic portal fibrosis?
So it is a sequelae of no, sir, I'm not aware.
Okay. I think let us investigate this patient. Okay. How will you plan the investigation in this patient?
First, if the patient is coming with the episodes of hematemesis, then we have to say first stabilize the patient by securing two periphery and central lines. Then cross matching of blood should be sent. Then serial hematocrit evaluation should be done. Nasogastric aspiration should be done. Then
This patient has come to you in the OPD.
Yes.
Okay.
So OPD first. Then we will first see liver function test. Then I'll investigate for ultrasound to know the status of the liver by looking into ecotexture. If there is any stages of any cirrhosis is there, then
Going to do only the ultrasound in this patient, or
after that we will proceed to endoscopy, sir.
No. Ultrasound along with in a suspected
portal Doppler, sir.
Yeah, you have to do so you will not do only the ultrasound, but you will do duplex scan. Why you want duplex scan?
To see if there is any thrombosis is present.
But that you can see on the ultrasound. Why the Doppler?
The size of the vein.
That you can see on the ultrasound. As the Doppler study shows, it shows the
flow of
ultrasound shows the anatomy.
Anatomy, sir. Yes.
While the Doppler shows the physiology.
Okay,
so
sir.
See for the flow of the blood.
Flow of the blood, yes, sir.
The significance of the flow of the blood in the case of portal hypertension?
So pressure will be increased, sir. So there will be
Have you heard about hepatopetal, hepatofugal flow? Significance of that?
No, sir. I will.
Okay, normally the blood flows to the liver for the
Yes, sir.
hepatopetal flow. But in the case of portal hypertension, it may become hepatofugal flow, that it comes out from the liver now.
Okay.
Okay, so that is the importance of seeing over the Doppler scan. So always ultrasound has to be combined with the
Doppler scan.
Doppler. Okay.
Then we can do endoscopy to see if there is any.
Have you done in this guy? Have you done?
Yes, sir. Endoscopy has been done, sir.
Have you the findings here?
Sir, actually, findings only esophageal varices was present, sir.
Nothing else.
Nothing else was there,
gastropathy and all those things.
No, sir.
What was the grade of the varices since it's bled, no?
Grade 2 varices, sir. Tortuous, not protruding, sir.
Okay. Any other stigmata of bleed? I mean, it had bled, and then obviously it has stopped, right?
It has stopped, yes, sir.
Any stigmata of bleeding remaining, like cherry red spot, watermelon stomach, all those ectasia of the stomach, all those were there?
No, sir. No, sir. No further. No signs of further bleeding was present, sir.
So, how did you stop the bleeding? Conservatively or
conservatively, sir?
Conservatively.
Really.
So now, what's your plan for this patient? For the plan?
See only the esophageal varices in your case?
No, sir. Actually, first we'll proceed till duodenum to see if there is any duodenal ulcer. Then we'll see pylorus, there's any peptic ulcer.
So what he meant was there are varices in portal hypertension.
Yes, sir.
Esophageal varices, and one more is there. Before you go to the
be there.
Before you enter the duodenum, one more is there.
Yes.
Fundal varices.
Fundal varices will be there.
Fundal varices. Now, why do you want to know which are the two types of varices? Why he asked that question?
To see if which one is bleeding, sir.
Not that. What is your management if there is a esophageal varices which has stopped bleeding, and what is your management if there is a fundal varix in your patient? Is the management different?
Esophageal varicose, we'll do if stop bleeding, we'll do a banding or sclerotherapy, sir, prophylactically.
Which one you want? Which is superior, banding or sclerotherapy?
Banding is superior, sir. Sclerotherapy has much more complications like perforation.
It does not. Why does one prefer a banding or a sclerotherapy? What's the reason why?
Technically more is.
What is the limitation of sclerotherapy?
It cannot be.
What do you use to do sclerotherapy? What is the substance used for doing sclerotherapy?
So sodium tetradecyl.
Sclerosant agent. What is the dose you put in each varus?
2 to 3 ml, sir.
0.5 ml it is.
0.5.
So if 2 to 3 ml, you do it for 3 viruses, how much it will be? 9 ml. What is the toxic dose of that sclerosant for the human being?
10 ml.
More than 1.5 ml is toxic for the patient.
Okay,
so at any given time, you can do only 3 viruses. So if you have 4 or 5 bleeding viruses, which is possible, you have to note down the number also. You didn't tell us. You just told grade 2. Then better to band it. That is why banding is superior to sclerotherapy. Second, sclerotherapy requires some technique. You have to, there's a learning curve to do it. Nowadays, gastroenterologists do all this. In my department, we only do it, that banding, EBVL. So that is much easier to do it, the EBVL, than the sclerotherapy. The training is not much required in that.
Is it easy to control the esophageal varices or the gastric varices?
Esophageal varices, sir.
And for the gastric varices, what you inject?
Sodium tetradecyl sulfate.
That usually doesn't work. You have to inject something better than that.
Poldocanol, sir?
No, not the sclerosant. Something else.
No, not the rest.
You know any glue?
Cyanoacrylate glue.
So for the gastric, usually you inject the cyanoacrylate glue for that, to control that. It is very difficult to control it with the sclerosants here.
Okay, sir.
In esophageal varices, the portal part and the systemic part, what are the names of the veins or the circulation which forms?
Sir, in esophageal varices, the portal vein is left gastric vein. The systemic counterpart will be esophageal vein arising, draining into ascites system, sir.
Left gastric vein, can you be more specific?
Coronary vein, sir.
Coronary. And what will be in the rectum? Lower
in rectum, there will be the superior rectal artery, superior rectal vein from portal system, inferior rectal and middle rectal vein from systemic circulation, sir.
How are you going to differentiate between the causes of melena if you have a patient of melena with black tarry stools, what you have mentioned, what the common cause of black tarry stools?
Black tarry stools. Maybe first we have to rule out any drug intake like bismuth, which is earlier given for peptic ulcers. Then we have to do upper GI endoscopy to rule out any malignant lesions in stomach and duodenum. Then any
Dr. Maheshwari, can we go on the management because it's already 9 o'clock, 1 hour has passed.
Yeah, sure, sir.
Blood investigation other than endoscopy, ultrasound, any other blood investigation?
Sir, CEA can be done, sir.
Why CEA?
Sir, no, sir, no, sir, not CEA, sir.
Tell about some basic investigations.
A hemoglobin can be done, sir, first.
Do CBC because already
CBC.
patient is bleeding, isn't it? Patient is
Yes,
bleeding,
sir.
want to know the hemoglobin percent, PCV. Then
Sir.
what next after CBC?
Then basic
Functional
investigation.
status of the liver. Functional status
Then
of the
liver
liver.
function test. Yes,
Yeah,
sir.
left it done. Then
Then a basic ultrasound can be done, sir.
that already you are told, isn't it? Ultrasound with
Yes.
Doppler.
Would you want to classify the ascites as exudate or transudate?
Yes, sir.
How would you do that?
Sir, in transferred protein will be less, and exudate it will be more. Glucose will be in transfer, it will be more or less equal to the blood plasma. The exudate it will be more. Specific gravity will be less in transferred. It will be more in either than exudate. Then serum ascitic albumin gradient will be increased in transferred, and it will be decreased in exudate. Yes, we can differentiate.
What would it help you
Yes, sir.
in classifying the differentials what you have spoken of?
Yes, sir. It will help us, sir.
So after all these investigation, would you like to grade your patient?
Child Puck score, sir.
Yeah. So what is the child Pucks in your patient?
9, sir. The Child Puck we will adding up to 9, sir.
In your patient, tell the values. Why?
Sir, first ascites, sir, 9, sir, ascites 3, severe ascites 3, then encephalopathy 1, 4, then albumin.
Yeah, first one.
Albumin,
Yeah. Tell about that. Yeah. How much is the albumin?
sir, albumin 2, sir. It is between 3.2 and 2.
Okay.
Yes, sir.
Bilirubin?
Bilirubin greater than 3, sir. 3.
Prothrombin time?
Prothrombin time 4 to 6 in 5, sir, 5.5 or something like 5.5, sir. It will
Why?
nearly
9?
10,
9 then, is it?
9, 11 it will come, sir. 3
Yeah.
plus 1 plus.
So which grade it is?
Child Puck C, sir.
Yeah, it is C. So what is the importance of knowing about whether it is A or B or C?
So it will management will be different, sir. For C, we have to do a liver transplant, sir.
Yes. And A?
A we can manage by shunts, sir. Shunt surgeries.
So for A, you can do a surgical treatment. For B, it is plus minus surgery plus endoscopic treatment. It is always the medical treatment or the liver transplantation is there.
Yes, sir.
So what is the plan in your patient now?
Sir, he might require a liver transplant, sir. Child Puck C.
How many people can get the liver transplant, So before that, the patient
Medical patient prophylactically dealt with propanol, sir.
What is intractable ascites?
Intractable ascites is ascites ascites even occurring after multiple paracentesis for salt restriction, furosemide dose of 80, spironolactone dose of 400, sir.
Right. So after giving all this, still you are not able to control. Surgical option for
then we have to go for surgical options like peritoneal venous shunt, sir, Levine shunt or Denver shunt.
Right. And after that, can you do any portal systemic shunts for the ascites?
Yes, sir. Yes, sir. If ascites is there, we can do end-to-side portocaval shunt, sir. Ascite to control ascites, sir.
And then finally the liver transplant for that.
Finally, yes, sir.
Right. Okay. So what are the various shunt surgeries which can be done for the portal hypertension?
So there are two types of shunts, sir: selective shunts and non-selective shunts. Non-selective shunts are again side to side that will include portocaval, mesocaval, and splenorenal. Then end to side portocaval shunt. In selective shunts, there are two types of shunts, sir: distal splenorenal shunt and Inokuchi shunt, sir.
What is the name of the distal linear shunt?
Distal, yes, sir.
What is the name of the distal liner in the shunt?
Warren shunt, sir. Warren shunt.
Warren shunt. Good. Yeah. So what are the selective shunts? One is the Warren shunt. Second,
It's the Inokuchi shunt, sir.
what is the other name of the Inokuchi shunt?
Coronocaval shunt.
Coronary caval shunt. No?
Coronary caval shunt.
Okay.
Which type of shunt is TIPS, Abhinand?
TIPS is actually non-selective, sir.
Yeah.
TIPS is not selective shunt.
Okay. What is the role of TIPS?
So TIPS is used in emergency or in transit between medical management and liver transplantation, sir. In TIPS we actually connect the one branch of portal vein to hepatic vein to portal vein via liver parenchyma and put a stent in between, sir.
Very good. In medical treatment, tell something about medical treatment for portal hypertension.
Sir, medical treatment, conservative management to reduce portal pressure, we use propranolol, sir. In emergency situations, we can use vasopressin octreotide, sir.
How does propranolol act? Beta blocker?
It will reduce portal flow, sir.
Yeah. Could cause flanking vasoconstriction, isn't it?
Vasoconstriction.
So how much propranolol you give?
80 mg, sir.
Fix case?
Sir?
Is it fixed in every case that you will give 80
No,
milligrams?
sir. No, sir.
Oh.
We can start with 80, sir. Then gradually reduce.
You have to bring down the
Propranolol
to less than 25% of that. So if somebody's basal pulse rate is 80, it should come down to 60.
Yes, sir.
The amount of the propranolol you have to give to these patients. Okay.
Yes, sir.
Right.
So can you summarize the treatment, Abhinand?
Sorry,
summarize the treatment pertaining to this patient. Pertaining to this patient.
For this patient, we can first start him on propranolol for now, then gradually evaluating for liver transplant if he is eligible. Then we can also try endoscopic banding also, sir.
Yeah, all the treatment should go hand in hand simultaneously, isn't it?
Yes, sir.
If patient is anemic, you have to arrange for blood transfusion. Once he has been made fit for endoscopic management, submit the patient for endoscopic treatment, isn't it?
Yes, sir.
You have to start beta blocker, propranolol.
Yes, sir.
You have to increase hypoalbuminemia component.
Yes, sir.
All the treatments should go hand in hand.
For the ascites also, ascites.
Yes, sir. Ascites there.
Any role of diuretics?
Yes, sir. So, diuretics. Furosemide, we can start, sir. Furosemide and spironolactone, we can start, sir.
Preferably potassium sparing diuretics.
Diuretics should be, sir. Potassium sparing diuretics should be.
Very good. So always treatment has to be customized to the
patient,
depending on the hepatic reserve function, which is what you have to child book classification.
Yes, sir.
Accordingly, you have to customize the treatment.
Yes, sir.
Good, Abhinand.
Okay.
Dr. Kanagavel, sir. Shall we proceed with second case?
Is Dr. Kanagavel there?
Please, sir. He's not there.
Not there.
Please continue with the second case.
I think can we go for the second case?
Sir, I will.
Thank you, Abhinandan. You can unshare your slide.
I'll answer.
And Dr. Jairam, are you there? Dr. Jairam? Dr. Jairam, are you there?
Has he gone off?
Dr. Jairam Prasad.
Dr. Jairam?
Has he moved him?
Probably he's not there.
Don't even have his number. Dr. Kanagavel to get his number.
Hello, sir. I'm there, sir.
Yeah, he's there. He's not on the video, that's all.
Okay.
Yeah, you start here. We will quickly wind up.
Can you share your slides? Dr. Jairam? Are you-
Wait, sir.
Don't know whether he's there or not. Dr. Kanagal, we are not.
Jairam, do you have any issues, Jairam?
No, sir.
Share your
Sir,
presentation.
is it visible, sir?
Yes, sir. We are able to see his slides, sir.
Okay.
Make it full screen, Jairam. Sorry, sir.
Okay,
Please
sir.
take over, sir.
Make it full screen.
Slideshow.
The lower part of your screen, there is a inverted bell is there. You have to press that.
Jairam
Sir.
plus F5.
Sir. Hello. Sir, can I start, sir?
Okay,
Can you
Jairam.
make it full screen, Jairam?
You are not able to make it slideshow. Start with that.
No, come to the right lower end. There is one screen type thing. Can you press with your mouse? Next to the 91%. You start presenting, Jairam. Let us not waste time.
Yeah.
Okay, sir. Myself, Dr. Jairam Prasad, MS General Surgery PG. My chief, Professor Dr. K. Saravanan MS from Madurai Medical College. A 38-year-old male patient, security by occupation, came with the chief complaints of multiple dilated veins in both lower limbs for
Slide.
past 15
Your
years.
slide. Go to the next slide. Can you go to the next slide?
Previous slide, sir.
No. You have to change the slide, as you present. Still, we are seeing only the title slide.
Jairam, you please unshare now. Sir, one moment, sir. Press what I said. Don't do anything else. Press share screen now.
Wait, sir.
What are the windows you get to see now? Do you see the PowerPoint of your thing seen there?
Sir, share screen option is available, sir.
Not available.
Window.
Okay, one moment, wait.
Sir,
Dr. Abhi, are you with us? Abhinandan? Do you have share screen option or not, Dr. Jairam? Can I request any one of the PGs to help him out? You can directly send me a message. I will send the PPT to you. Anybody, any volunteering one?
So shall I run it straight away?
Sir, you have it, sir.
I have share here. I have a MacBook.
Sir, please, sir. I will request. Very sorry to do this.
No, you just share it quickly to me. Quick. To the phone, you share it. Share it to the WhatsApp, sir.
I am doing it, sir.
Yeah.
Sir, I edited that PowerPoint, sir.
Kana, when you are not able to pay, people cannot wait. All of them are senior professors.
Okay, sir.
Give it, sir. No problem.
Unless you are able to play it, we will not be running the class. We cannot
Kanagwel, sir,
keep
send
waiting
it.
for good, right?
Kanagwel, sir, send it.
I am doing it.
Yeah, it came, no? It's there already with me.
Yes, sir. It is with you, sir. Same thing.
Yeah, same. 1 minute. I'll airdrop it. Wait. So
yeah.
Let's open here. Is my screen shared now?
Yes, sir. Yes, sir. We are
Yeah.
able to see your laptop. Request you to open the PowerPoint.
Yeah, 1 minute.
Yes, sir.
Yeah. Now?
Yes, sir. There we go, sir. Thank you, sir. Thank you. Sir.
Yeah, 1 minute. I will start the
Make it full screen play mode, sir. Yes, sir.
Now
Yes, sir. Perfect, sir. Perfect.
Okay, shoot, boss.
Thank you, sir. Sorry for the inconvenience.
No, it's not an inconvenience at all. It is
yes.
My duty actually. Chalo.
Yes, sir.
Go on, boss. Don't stop.
Dr.
Jairam,
Jairam.
start presenting.
Sir, audible?
Yeah, go ahead.
Perfectly audible. Please start.
38-year-old female patient came with complaints of multiple swelling in both lower limb for past 15 years.
Again, what I told in the last, what do you call, last presentation, dilated tortuous veins. Transcribe it rather than multiple swellings, Otherwise, we'll think it's lipomas, no?
Okay.
Dilated tortuous veins. You can use the English word. I mean, you already passed your MBBS. Now, for MBBS, it is okay to tell like this. Not for pastors, okay? Fine, next.
History of presenting illness. The patient was apparently normal 15 years back. After which, she started developing multiple swelling in both her lower limbs. Initially started below, gradually progressed upwards, attained the current size.
Can I go to the next one?
Yes, sir. History of itching present. No history of ulcers in lower limb, no history of bleeding, no history of pain, no history of trauma, history of discoloration of lower limb present, no history of difficulty in walking, no history of difficulty in standing, no history of deformity of lower limb, sir.
Yeah. Hello.
Yes, sir.
No history of abdominal pain. That's why you're at. Hello.
Yes, sir.
Can I call you back? I'm in a meeting, Zoom meeting. Anything important? Anytime, Namar. Yeah, thank you. Any issues there? Any issue, sir? Anybody else? Am I audible?
Sir, you're perfectly audible, sir.
Is the slides seen?
Slides are moving, sir, very well, sir.
But he is like perplexed.
Sir, I think he should join in his mobile, sir. The problem is with laptop or his Zoom, sir.
Yeah, there is no history of abdominal pain. Next one. No history of abdominal distension. No history of constipation. No history of bursting type of pain. Why are you asking this bursting type of pain, sir? Any idea?
Sir, to rule out DVT, sir.
To rule out DVT. There is no history of swelling in the limb. For what purpose did you ask that?
Not needed, sir.
Yeah. No, whenever the patient tells, like there is a swelling. So my suggestion, like it's a useful suggestion, never to ask history of findings. Never to ask history of findings unless the patient volunteers it. If the patient says he has a swelling, he has a distension, then only you should ask him. Then only you should tell that. Otherwise, there's no need to ask that. Why did you ask for history of chest pain, breathlessness, palpitation, and hemoptysis?
Sir, this history related to pulmonary embolism, sir.
Right. Go on. Can you see the slides?
Yes,
Dr.
sir.
Jairam, try to limit the negative history. Jairam.
Okay, sir.
Try to limit the negative history. Your history should comprise more of positive history than negative history. Okay?
Okay, sir.
Okay.
Past history of similar complaints for the past 15 years, for which initially she was advised grip bandaging at a private hospital, after which she was last follow-up. It's a known case of systemic hypertension for the past 5 years, tablet amlodipine 5 mg OD, not a known case of diabetes mellitus, tuberculosis, bronchial asthma, heart disease, kidney disease, and epilepsy, sir. No history of chronic drug intake, no history of previous immobilization, no history of previous lower limb surgeries, um, history of LSES in 2007 and history of LSES in 2016, history of hernioplasty done for left-sided hernia, history of abdominal hysterectomy done for menorrhagia fibroids, sir.
Any idea what sort of hernia? Being a female, no?
Yes, sir.
You are not knowing which side of hernia.
Sir, it's inguinal hernia only, sir, not a femoral hernia, sir.
How did you come to know? It's a femoral or inguinal.
Patient have a record, sir. Treatment history.
Through the records. Okay, fine. Fair enough.
Personal history. She's a book by occupation, consumes mixed diet, no specific addiction or habituation, normal bowel and bladder habits, and normal sleep pattern.
I have
Family
a problem with this number 3. Okay, I don't know whether others have a problem. What addiction are we talking about? And what habituation? For the sake of using flowery English, don't do it. Okay?
Okay.
Yeah. I'm an English language writer. So I in presentation don't use that language. Simple. In writing we use. What addictions are associated with diseases? Can you tell some addictions, please? Is it drug addiction, cocaine addiction, marijuana addiction? See, you should be specific. What is
alcohol.
the one smoking and alcohol? Common vices in this world, right? And tobacco chewing, 1, 2, and 3.
Okay, sir.
These 3 we have to elicit. Okay.
Okay.
If the patient says I was a cocaine user, marijuana user, I use some drugs, then you have to tell it. Instead of telling, there is no history of smoking, there is no history of alcohol, there is no history of tobacco chewing. Clearly associated with vascular disease or with cancer. Clear?
Okay, sir.
Why you want to put it like this? Simple, no? Simple English you have to put. No history of smoking, no history of alcohol, no history of tobacco chewing, in our country at least. Fine?
Okay, sir.
If you are instructed to tell like that, I think you should rebel against that instruction. Okay?
Okay.
Thank you. Next.
Family history, no history of similar complaints in any other family members, sir. Attained menarche at 13 years of age, 5 or 60 days irregular cycle and normal flow. Attained surgical menopause at the age of 31, sir. Obstetric history,
Wait. This is some new term I'm hearing. Is it a standard term? Is it an accepted term? Surgical menopause. First time I'm hearing it by short clinical teaching. Any of the seniors, please, sir, step in, please.
I also edited all these slides, sir.
No, that's okay. But these are your original slides, no? So, what is surgical menopause? What is menopause? First of all, what is menopause?
Complete cessation of menstrual cycle, sir. For more than 1 year, sir.
Okay. Because she underwent a hysterectomy. Well, let's not go there. Menopause. The patient is not able to determine because patient undergone hysterectomy. That's how you have to tell it. Okay. Menopause means stopping of the ovulation of the cycles, ovulatory cycles. Okay.
Yes, sir.
Right. Go on.
Obstetric history, para to live to, first child 2007 LSES female baby, second child 2016 LSES male baby, sir.
Any positive findings in the examination? Any positive findings?
Yeah. Well.
Dr. Jairam, are there any positive findings in the general physical examination?
Yes, sir. Hyperpigmentation of skin in the gaiters area, sir.
That is a local examination.
That can, we can tell local examination.
Local examination. Shall we
Vital
skip
is
this?
normal, isn't it?
Sir,
Yes,
shall
sir.
we skip this, sir, Manjunath, sir?
Sure, sir. Please skip, sir.
Yeah.
Vitals also normal. You can skip this also, sir.
Examination of both lower limbs. After explaining the procedure and getting consent from the patient with the adequate exposure from umbilicus to toe, patient examined in standing posture. Attitude and is normal, no deformity, no obvious lengthening and shortening of limbs, sir. Dilated, elongated tortuous vein noted along the medial aspect of leg, extending from toe to the knee, sir. From ankle, medial aspect of the ankle to the knee, sir.
Can you say which vein has been involved here, Jairam?
Great saphenous vein, sir.
You mentioned that, isn't it? Instead of staying on the medial aspect of the leg, commit it as long saphenous vein or great saphenous vein, isn't it?
Okay, sir.
Okay.
Skin over the limb, no scars.
Tell the positive ones. Positive findings.
Multiple blowout present, sir. Pigmentation present. Expansile cough impulse present, sir.
Palpation.
Palpation, not warmth, not tender, no pitting edema, skin thickening present, lipodermatosclerosis present. All other inspectory findings confirmed, sir. Special test, Brody Trendelenburg test 1 and 2 positive. Multiple tourniquet test, incompetence at mid-thigh and piloni perforators. Modified Perthes test, the vein is deep veins, pattern deep veins. Spots test, impulse felt at cephalofemoral junction.
What did you say? I want clarification. Modified Perthes test. What did you say?
Pattern deep veins, sir.
Yeah, you have written Perthes test also there. Both are written. Probably want to delete that also, na? That's
Yes, sir.
What is the difference between modified Perthes and Perthes test?
Perthes test is subjective, sir.
Perthes test is not
It's
subjective.
subjective.
Both, okay, maybe the interpretation like that, but what is the difference? Technical difference.
Sir,
What is the difference in a technique of a Perthes test and a modified Perthes test?
In Perthes test, we use grip bandage, sir.
Okay, that's
After
not the
applying the grip bandage, and ask patient to walk, sir. If
that's
patient
not the difference. That is not
complaints
the
of pain, it's Perthes test.
In Perthes test, we empty the vein.
Yes, sir.
Whereas in modified Perthes test, we do not empty the vein.
Okay, sir.
Okay.
Sir,
After that, we occlude this. Yes.
I think whether it is a Perthes test or modified Perthes test, this is the one test where we don't empty the veins. Let it be Perthes or modified Perthes. Veins need not be emptied. But only thing, as you told, one is subjective, another is objective.
Okay.
Depending on patient complaints, you can say Perthes test
Actually,
positive or negative.
come in, please. Actually, in Perthes, they used to use the Eschmark bandage.
Yeah, it is not. Yes, sir.
And in modified Perthes, they're using just a tourniquet.
Only
when they
tourniquet.
use a Eschmark, you cannot see whether the veins are dilating or not. So that is why it was done away with, and then we had this modified Perthes that's just a tourniquet, so you can see the veins dilating or not when the patient is doing activity or to rule out DVT.
Yes, sir.
Then Pratt's test. Did you do the Pratt's test?
Yes, sir.
Describe.
Sir,
Describe the Pratt's test.
Patient in lying position, elevating the limb at 45 degree, empty the superficial vein, sir. A tourniquet is applied at cephalofemoral junction. Then grip bandage applied from.
That is a Eschmark's bandage is in Pratt's test. Eschmach's bandage is in Pratt's test. Okay.
That
Krebs bandage is in Fagan's test. Fagan's test is correct. That is why these tests are all superfluous and overlaps. What is the main test we want? Main 3 tests we want in varicose veins.
Trendelenburg and
first is the inspectory test, is the Morrissey's cough impulse test. The Morrissey's cough impulse test, there is a cough impulse at the saphenofemoral junction. Differential diagnosis, femoral hernia. Okay.
Okay.
Which side has the surgery undergone? For
Left
hernia?
side,
Left side.
Actually, in varicose, sorry, sir,
Which side is?
May I come in, sir? In varicose, we got to test for 3 things. One is the saphenofemoral, other is the perforators, and third is the deep venous system. So all these tests are for either of the 3, right? These are the only 3 important things which you have to be tested in varicosities: the saphenofemoral, the perforators, and the deep veins.
Yeah. But where is the scar on the inspection of the hernia surgery? You are not described the scar. Which side is it, right or left?
Left, sir.
So left side is the cough impulse?
Yes, sir, present, sir.
Yeah. So what surgery was done, you are not sure. No, unless in exam you won't be given the records. So where is the scar? Have you described on inspection the scar?
No, sir.
See, that is called banana peel. You know, you are seeing the banana peel and you'll slip on it after seeing it. So missing a scar is not pardonable. Okay. You have to describe the scar, especially it's on the same side. Plus there is a cough impulse there, Morrissey's cough impulse. So what is the DD of a cough impulse at the saphenofemoral junction?
Saphenopharynx, sir.
What else can occur there in that area where you get the
femoral hernia?
How do you differentiate a femoral hernia from a saphenopharynx?
In auscultation, in saphenopharynx, venous hum is there, sir. Both swellings will reducible and lying down, sir.
Both will reduce on lying down, which will have a thrill and which will have a impulse, expansal impulse. Okay, you really did the Homan and Moses test? Really, you did it?
No, sir. Actually, we will not do that test.
You should not put the test for the sake of putting it up to show that you know them. They are of no practical value. And Homan's test and Moses test should not be done in DVT. They're mentioned to be condemned. Why? Because they can trigger a pulmonary embolism.
Pulmonary embolism.
Correct. And they have no value. When you have much better things, tests. So only 3 tests, like somebody rightly pointed out: saphenofemoral junction incompetence, multiple tourniquet test, and modified Perthes test. All others are confusing and superfluous. Okay. Can I go to the next one?
Yes, sir.
Yeah. When you are doing the multiple tourniquet test, how many tourniquet did you apply?
Sir, one above knee, one at SFJ, one tourniquet, sir. Above knee, one tourniquet, sir. Below knee, one tourniquet. Above ankle, one tourniquet, sir.
Above ankle, how much above ankle? What are the commonest?
Below 5
what are the
less than 5 centimeters from medial malleolus, sir.
5, 10, 15 centimeters, no?
Yes, sir.
Okay. So you applied these tourniquet and then how did you open that? How did you open the tourniquet?
Sir, from above, sir.
It has to be always from below. The lowest one has to be opened first, not the upper one.
Okay, sir.
So it has to be sequential from the lower side going up.
Okay, sir.
Right? Okay.
Examination of lymph nodes, no clinically demonstrable lymph nodes. Examination of adjacent joint, both active and passive movements normal.
Which are the adjacent joints you mean, Jairam?
Knee joint, sir.
If there is a ulcer, you can mention the adjacent joints. one joint proximal and one joint distal to the site of ulcer. There is no ulcer in this case, isn't it?
Yes, sir.
Simply we can say all the joint movements are normal in the lower limb. Don't say adjacent.
Why
Okay.
you want to examine them first of all? Like, is there any reason?
Without venous ulcer.
Why do you want to examine a joint?
Sir, in case of pain, to rule out whether it's belongs to ONE.
So ONE will have a pain in the, where is the pain be? ONE, osteoarthritis you mean, no?
Yes, sir.
Yeah, one more thing, when you're talking, don't talk in abbreviations. Full form.
Okay, sir.
Okay.
Sir.
First time when you talk, full, then abbreviation. Okay.
Okay.
You're not messaging in the WhatsApp or the Instagram. So your clinical examination, full form.
Okay.
Yeah, go on. And side is not written anywhere. Huh? Which lymph nodes have you examined? Right side or left side? Why you examined? If you examined both sides, why you examined both sides? Which side you examined? Have you written? No. Which
No,
side
sir.
you meant lymph nodes?
Both sides, sir.
Yeah. Why both sides you examined? You were thinking of lymphoma? What is the lymphatic drainage of the limb? Right limb, left limb. Does it go to the other side? Is it unilateral flow or bilateral flow?
Unilateral flow, sir.
Then why you examine the other side?
Sir, we as patient have varicose vein on both legs, sir.
No, but why you examine on which lymph nodes did you mean? Which lymph nodes has been operated? Which side has been operated?
Left side, sir.
Which lymph nodes you should tell?
Right side, sir.
So if you operated on the left side, you should say right side lymph nodes. Doesn't make sense. You should put the side. You should be very clear about the lymph nodes. Left, which lymph nodes here? Which lymph nodes you have to tell? Aortic lymph nodes, supraclavicular lymph nodes, cervical lymph nodes. Which lymph nodes you want to tell? Axillary nodes in this patient.
Inguinal lymph nodes, sir.
Then please tell that. Nah. On examination, the left side inguinal lymph nodes are not palpable. On the right side, inguinal lymph nodes are not palpable. Then we will ask, why did you? We understand why you asked on the left side, but right side, why you asked? What's the reason?
Can the bones or the joints be involved in case of varicose veins?
No, sir.
Yes, that's also wrong. What is callipus? Callipus.
Sir, actually, in callipus, the fibrosis of Achilles tendon causes Euchinus deformity, sir.
Yes. Can bone be involved before that?
The joints and the bones are involved in the case of varicose veins also. It's called as phleboarthrosis. Okay, the term is phleboarthrosis.
Okay, sir.
So it's a known entity in the case of the varicose veins. You know?
Now this one. Any problem in the peripheral pulses?
Nothing, sir.
Why do you examine the peripheral pulses? As a matter of routine, or you are looking for some etiology or anything like that?
Sir, in case of DVT, the extreme edema causes compression of arterial system, sir.
So what's the significance? On inspection, your patient doesn't have that extreme, what did you say? You used that word, no?
Edema, sir.
Is there extreme edema?
Swelling? No, sir.
Okay, fine. So what's the reason to examine the peripheral pulses?
Routine examinations.
No, that's what you're wrong. See, remove the word routine from your dictionary. Everything which is having a, you do should have a reason, scientific reason. So why we are doing peripheral pulse examination is if the peripheral pulses are absent anywhere, then your conservative management should be careful. Okay, we'll come back to it when we discuss the conservative management. Next is me on your slide. Okay.
All the pulses are low volume here. You know how to write for the pulses? When you write 1+, what does that mean?
Sir, actually, the flow is
What are the various grades of the pulsations?
sir, triphasic, monophasic, or biphasic.
Not
That's
not
Doppler. That's
one
Doppler.
plus. Tell about that.
Palpatory.
1 plus is written.
So not audible, sir.
You're not
He
audible.
says you have put 1 plus, whereas 1 plus depicts a feeble pulse. It doesn't say when you make a chart of a pulse in a clinical examination, you have 3 plus, 2 plus, 1 plus, and then minus. 1 plus means a feeble pulse. 2 plus means just below normal. 3 is a bounding pulse. Okay.
Okay.
So you have written it like this, saying that it's palpable to indicate it is palpable. But when a clinician reads this, he'll think it is a low volume pulse. Fine.
Okay, sir. Examination of nervous system, sensation intact, muscle power, fiber firing, sir.
Normal, abdomen normal?
Yes, sir.
Why did you examine the abdomen? What are you looking for?
Looking for any pelvic congestion, sir.
Pelvic mass.
Pelvic.
Yeah. Just as normal?
Yes, sir.
So how do you differentiate? Yeah. How do you differentiate a varicose veins because of a pelvic mass versus a varicose veins without a pelvic mass? What is the difference? Okay. A pelvic mass on elevating the limb, varicose veins will not disappear.
Okay.
Whereas in a primary varicose veins, without a pelvic mass, the varicose veins will disappear.
Okay, sir.
What's your diagnosis?
Sir, a case of chronic venous insufficiency involving a bilateral lower limb with involvement of great stiffness system with perforated incompetence with no DVT, sir. CEAP, C4, EP, anatomical superficial and perforator, pathological reflex presence, sir.
Okay. Can I unshare the slide now so that I can?
Yes, sir.
Fine. Anybody wants to go back and front, sir? Anybody? Any of the teachers?
There you have written no pigmentation.
Sir, actually, I edited that one, sir.
Is that correct?
Yeah, pigmentation present, sir.
Yeah. It is obvious, no? It is obvious there is a change
Yes,
in
sir.
the...
Yes, sir.
Jerome, can you tell us the cause of hyperpigmentation?
Sir, in case of chronic venous insufficiency, causes increased capillary pressure, leads to leakage of RBCs and WBCs. Sir, the RBC rupture causes hemosiderin, will cause hyperpigmentation, sir.
What is the cause for venous ulcer? If at all a varicose vein patient develops that?
What, sir?
What is the cause for venous ulcer formation?
The theories of venous ulcer formation. Hypothesis behind them. Some theories are there, no?
Yes, sir. White cell trapping theory, fibrin cuff theory, sir.
Explain to us, like a 5-year-old. Entrapment theory.
May I come in, please? There's a difference between varicose ulcer and venous ulcer. Okay?
Yes, sir.
There's a difference between the two.
Yes,
so,
sir.
do you know the difference between the two?
Yes, sir. In secondary to post-thrombotic results in venous ulcer, sir. If
And
due
varicose?
to varicose ulcer due to superficial venous system.
So how will you know whether this is varicose of this venous ulcer? By look. Varicose ulcer will be superficial, not penetrate into the deep fascia.
Yes, sir. When venous ulcer, base
So,
is
right.
deep to the deep structures, sir.
Right. So venous ulcers will not heal once you treat the varicosities, but
Yes,
a
sir.
varicose ulcer may.
Present, sir.
Sorry, please continue.
So how you are going to investigate your patient?
Sir, routine investigation, sir. CBC, RBS, RFT, LFT, serum electrolytes for ECG, X-ray, sir. For varicose vein, I
You know,
go
in
for
any routine investigation, they always come afterwards. No? Always
Okay,
the investigation which are there is a diagnostic investigation. You have to make a diagnosis first. Then you have to go for all those routine investigations for the treatment purpose. So what is the diagnostic investigation here?
duplex ultrasound, sir. Go.
What do you understand by duplex ultrasound?
To know the extent,
Now, what is duplex ultrasound?
sir, both Doppler and ultrasonogram, sir.
Which ultrasound?
High frequency ultrasound.
You know, there are different modes are there.
B mode, sir.
Why you want to do ultrasound and why you want to do a Doppler?
Sir, to know the extent reflex in great deafness system, to know the patency of deep vein, sir.
So what do you get by ultrasound? In a case of varicose veins, what are the things you see by ultrasound? And what are the things you see by the Doppler?
Doppler to use for to see the flow, sir. Doppler
You see by the flow of the blood.
is for retrograde or antigrade flow.
Ashok Mansoor's number, sir, if you have.
What thing gives that reflection of the waves?
Yeah.
You know, when you're putting the Doppler sound there, what is the thing which is reflecting the, giving the waves there?
In venous system, it is monophasic flow, sir.
In the venous, what is there?
Monophasic flow, sir.
Venous is monophasic flow. Who
Yes,
said
sir.
this is monophasic? What is there in the vein?
Valves, sir.
Hmm?
Valves.
What thing gives the Doppler waves? You know, basic principle is the sound waves there, you know?
Yes, sir.
That you throw the sound waves and they are reflected back.
Yes, sir. Through hemoglobin, because of hemoglobin in RBCs, sir.
RBCs, you know?
Yes, sir.
Throwing RBCs are there. And what is there in the RBCs?
Hemoglobin contains iron. Iron reflect the waves.
So there's the iron which is there inside the hemoglobin inside the RBCs is the, which is reflecting the waves there.
Waves, yes, sir.
You know which animal uses the Doppler for flying?
Dolphin.
Any idea?
Dolphin.
Travel in the night.
Bat.
Owls.
Bat.
Yes, okay.
Yeah, bat.
Bat.
Bat can travel in the night. In a closed room, in the dark room, it can travel
Yes.
without hitting the walls. Okay. So what you want to see in the duplex scan in varicose veins?
To see the patency of deep vein.
Patency in the deep veins. That's the most important thing, yes.
Yes, sir. To rule out extension of varicosities in superficial and perforator system. Then to
Say the
treatment of choice.
incompetent.
Incompetent faults.
Say?
Choice of treatment.
No, on the duplex, how do you say that this saphenofemoral junction is incompetent?
By doing Valsalva, sir.
Hmm?
Doing Valsalva maneuver.
What thing tells you that this is incompetent? That there is a reversal of the flow is there.
Yes, sir.
So when you say this reversal is pathological and you label that it is incompetent, if it is more than
0.5 seconds.
if it is more than 0.5 seconds is there,
Seconds.
then you label that it is a incompetent.
Okay, sir.
In the perforator incompetence, how do you say it is incompetent for the perforators?
More than 1 second, sir.
Hmm?
More than 1 second, sir.
More than 1 second. 1 second is very severe. Okay. It's again either the 0.5 second, but many of the people, they accept also the 0.35 seconds.
Okay.
Okay. And plus, there is always that there has to be defect in the deep fascia of more than 3.5 millimeters.
Okay, sir.
Then you label that particular perforator as the incompetent perforator. Okay, we have to measure the size of the GSV, the great saphenous vein in the thigh or in the leg, which is an ideal place where you will measure that to tell this is an incompetent one or it's a dilated vein. What is the usual site where you have to measure the diameter of the vein?
In leg, sir. In leg.
Not in the leg, it is used in the thigh. But where in the thigh? Used in the mid-thigh.
Mid-thigh, sir. Mid-thigh level.
To the saphenofemoral junction, in the mid-thigh, you always measure there. And there, if you find it is more than 4 millimeters in size is there, then you say it is a dilated vein is there.
Nice side.
Right. Any other investigation you want to do? To see for the secondary type of the, if you have to see for the secondary type of the varicose veins, what other investigations you are going to do?
MRI venogram, sir.
Yeah. First, you have to see the secondary. What are the usual causes of the secondary type of the?
Post-thrombotic sequelae.
That you have seen already, that there is no thrombosis of the deep veins is there. Any other thing which can lead to the secondary type of the varicose veins? Any pelvic tumor?
Yes, sir.
Okay. Or a pregnant lady is there. No, it can be there. Or there can be when a fistula may be there. All these are the causes for the secondary type of the varicose veins.
Okay.
When you do the venography, what is the indication of doing the venography?
In case of post-thrombotic thickening or scarring.
Usually, if it is a recurrent vein is there, okay.
Yes, sir.
You have done the superficial ablations, but the patient comes back to you with a recurrence. Then you have to see for what is happening to the deep veins there, whether deep walls they are patent or not. So in those cases, you carry out the venography. What are the venography?
Sir?
What are the various types of venographies?
And it should be only the medical.
Sorry, sir.
So you can do MR venography, you can do the CT venography, invasive venography, ascending or descending type.
Okay, sir.
IVUS, IVUS.
I will also talk with Tarasu. I told him that you will call him today.
IVUS is intravascular ultrasound.
Okay, sir.
Okay. So IVUS is again mainly done for the deep veins, not for the superficial system, but for the deep system. But otherwise, in a case of varicose veins, the only investigation which is the duplex scan only.
Okay, sir.
So what you will plan for your patient? What is your planning?
Sir, my patient is the symptoms more in left leg, sir. So I first treat left leg with endothermal ablation, sir.
Endo?
Thermal ablation, sir.
Okay.
You want to go with non-surgical minimal methods, EVLA, endovascular laser ablation, or endovascular radio frequency ablation. You want to do those methods.
Yes.
Why? Why do you prefer that? What are the prerequisites to do that?
Do you have the facilities for that, Jairam?
Yes, sir.
Do you have the machine there with you, laser machine?
Hospital?
Yes, sir.
EVLA and endovascular intravenous radio frequency ablation.
Sir, radio frequency ablation in our college doing, sir.
You have? Very good. What are the indications for that?
T-pain must be pattern, sir.
Right.
And you should use a Doppler, right?
Yes, sir.
Doppler knowledge should be there. Okay.
What are the tools apart from the laser and the RFA, which can be used for the varicose veins?
Sclerotherapy, sir.
No, thermals. You said that thermal ablation. So it can be done with the laser, done the RFA. Any other thermals, You can do it with the microwave. Or you can do it with the steam. Okay, these are other ones, apart from the laser and the RFA.
Okay.
And what are the various non-thermals ablations? These are thermal ablations. What are the non-thermal ablations?
Sclerotherapy, sir. Sclerotherapy, foam sclerotherapy.
Yes,
Sclerotherapy.
Yes. What else?
Mechanical and chemical.
Yes. MOCA, that is called a MOCA. Mechanico-chemical ablation,
Yes.
And third is?
Glue. Cyanoprene glue.
Glue. You can. So they are the non-thermal.
Yes, sir.
And you know what is HIFU? HIFU?
Sorry, sir.
It is high frequency ultrasound. Okay, this is a non-invasive method.
Okay.
Non-high frequency ultrasound.
Okay.
What is the surgical treatment for the varicose veins?
Flush ligation of SFJ, sir. Flush ligation of SFJ.
Yes.
Stripping.
You just only do the flush ligation or something else also done?
Definitely stripping also, sir.
Okay, surgical stripping is done. Anything else?
Blepharectomy, sir. Blepharectomy.
No. At the saphenofemoral junction, do you do something else?
What do you mean by flush ligation? We are only going to ligate the vein, or anything else you are going to do there? What will happen to the tributaries?
6 tributaries we have to ligate, sir.
6 tributaries you are going to find out.
Yes, sir.
What are the 6 tributaries?
Superficial circumflex, superficial inferior epigastric, superficial external pudendal, deep external pudendal, anterior accessory, posterolateral vein, sir. Thigh.
Is it necessary to ligate all the anterior and posterior accessory veins for doing a flush ligation?
Yes, sir.
No. What do you mean by the word flush ligation?
Close to the saphenofemoral junction, sir.
How do you find out which is Superficial epigastric or circumflex iliac?
Superficial circumflex iliac is in lateral to the thigh, sir. Superficial epigastric goes upwards, prudental medial, sir.
What is that? Which femoral vein it will join?
Common femoral vein, sir.
How the common femoral vein is formed?
Hello, sir. Sorry, tomorrow, okay, because I'm still in the meeting.
Deep femoral
I'm in the
and
national
popliteal vein, sir.
Suddenly I
Popliteal
committed.
vein.
Yeah.
Popliteal
Sir,
vein, deep femoral will form the common femoral.
our friend. Yeah. What happens now? Will he come or not come?
And anterior accessory vein, sir.
No. He said how the common femoral vein is formed. Popliteal vein continues as what vein? It continues as a superficial femoral vein.
Sorry.
Then what is deep femoral vein? How the deep femoral vein is formed? So all the pelvic veins, the veins from the muscles, you have a gluteus maximus, the main veins supplying the muscles, all that join together. It's a small vein, relatively small vein. Then it forms the common femoral vein. And you said you will also strip. And from up where to where you will strip?
Up to knee, sir.
Why not below the knee?
Because below peroneal arch vein communicate with the peroneal vein, sir. So perforators.
Arch vein communicates with the peroneal vein.
Yes, sir. So no need to.
So arch vein is on which side and peroneal vein is on which side? What is the arch vein? Posterior arch vein of Leonardo, where it starts?
From it communicates with the peroneal vein, sir.
Peroneal vein is in which compartment?
Middle compartment, sir.
It is in the middle compartment. It is going to the lateral compartment.
Okay.
So you are talking about the vein here. So one reason it is not communicating with the posterior veins. So that is the main. What are the other reasons why you are not going to strip below the knee?
Saphenous nerve is along the great saphenous.
Where do you saphenous nerve is coming from? Is it a motor nerve or sensory nerve?
Sensory nerves.
Is it coming from the femoral plexus or sacral plexus?
Sorry, sir.
For that, you must know what are the veins of what are the nerves of the sacral plexus. Then, so it is not coming from the sacral plexus. All the nerves from the sacral plexus, most of the nerve will start with the P. So one is saphenous nerve may be injured. One is by stripping the deep superficial saphenous vein. Our intention of stripping is one is a perforators. Where here at the lower perforators are not connected with the superficial femoral vein, so it is not going to serve the purpose. Third one is the saphenous vein may be utilized for the other purpose.
Okay.
Sir, can I sir please continue?
What are the various complications of the thermal type of the ablation? And how do you prevent them?
Deep vein thrombosis, sir.
No.
How do you prevent the deep vein thrombosis?
From obliteration 3 centimeter from SFG, sir.
At least 2 centimeter proximal to that.
Yeah, SFG.
Should be proximal to that. And if it is You are injecting the glue there, then how much proximal you are? If you're putting the glue in the vein,
Okay, sir.
how much you should be away from the saphenofemoral junction?
Sorry, sir. Don't.
Should be 5 centimeters.
Laser, you start ablation from lower or above? Down. The ablation procedure on the laser RFA, you start from above or below?
From above, sir.
RFA also. So glue, what is the mechanism of its functioning? Glue.
Endothelium will adhere to each other, sir.
So much of endothelium, then it will go into the vein also, into the saphenofemoral junction also. What is the
That's why
mechanism? Because you are going to inject only a small amount. The vein is much dilated. What is polymerization?
What is tumescence?
tumescent local infiltration of anesthetic agents, sir.
What is the purpose of giving the tumescent anesthesia and the thermal ablation? What is the purpose?
For to create a 10 mm halo around the saphenous veins, sir. To prevent pain and to prevent injury to the adjacent structure, sir.
What injury?
Because of a thermal injury, sir.
Okay. That's one reason. Any other reason?
Because of injection, that vein come close to the, so ablation of vein will be easy, sir.
Okay. How do you prepare the tumescent?
Sir, 445 ml of normal saline, sir. 50 ml of 1% lidocaine, sir. 5 ml of 8% sodium bicarbonate, sir.
What is the maximum dose of lidocaine you can give? How much, if you are allowed to do a lignocaine or lidocaine, how much you can give for individual? Suppose you are going to operate on an individual of just 30 kg.
Okay, sir. But it causes arrhythmia, that's why.
Okay, there is a fixed dose. No, what is the dose? It is only 2 to 5 milligram per kg body weight. So if you want to dose in large volume, you should can add adrenaline. Adrenaline you can give up to 7 to 8 milligram per kg body weight. So
Okay.
how do you dose? If you want to give a lignocaine, can you make it a 2% solution or 1% solution? How do you make 2% solution to 1%?
Sir,
What do you make 1% solution?
sir, preformed solution is 1% only.
What do you mean by 1% solution?
Sir.
It is a 1 part in 100. So suppose you are having a 2% solution. If you can dilute it with another 50 ml, it will become a 1. So if you want a larger dose to use, it is better to use the 1% solution is ideal. You can use up to, if it is a 2 to 5. But there is no specific indication like 50 ml we need to add. So the maximum dose you should know. How much you can maximum you can use the lignocaine.
Okay.
Anything else you add? The tumescent?
Adrenaline, sir.
What is the use of using adrenaline?
Vasoconstriction.
Vasoconstriction. It is going to constrict the vein. Large saphenous vein, it is going to constrict.
Sir, it makes the adrenaline action most potent, sir.
It makes the absorption of the lignocaine less. So you can use a large volume of the lignocaine you can use. If you are using adrenaline, you can use up to 7 to 8 milligram per kg body weight of lignocaine can be used. If you want to use a large volume of lignocaine.
Okay.
In fact, this surgery you are going to do with already anesthetist individual. So lignocaine is not going to be the most important thing it's used.
Okay.
What are the various agents which can be used for the sclerotherapy?
Sir, 3%, 3% NaCl, sir. Initially, in older days, it used to 3% NaCl, sir. Now, 3% sodium tetradecyl sulfate, 3% polydecanol, and 5% ethanolamine, sir.
What is Tessari method?
Sir, foam sclerotherapy is called Tessari method, sir. In 1:4 or 1:3, O2 is mixed, sir. Oxygen is mixed, sir.
What is 1:4? What is 1? What is 4?
One is sclerosant, sir. 4 is air, sir.
You can take air, you can take oxygen, you can take CO2. All,
Yes.
but usually it is the air. No? Right.
Why do you want to use air and or CO2?
Sir, easily available.
Not easily available. Why do you want to make it 1:4? Why not use as 1? Just a sclerosant. What is the purpose of adding more this? The volume which you are going to use, because 1 ml cannot produce a particular area only, it can the volume. So here we are making where you are going to make it a large volume, large area of the scan, you can do that. What is an absolute contraindication of sclerosant?
Allergy, anaphylaxis.
This is all relative contraindication. Somebody who has have a congenital anomaly with the heart, what anomaly? Persistent foramen ovale.
Okay, sir.
There is a one if you know the patient is having a suffering from this and you should not use, there is a remote possibility it can produce a complication for embolization.
Okay.
Well, we
What
can
is the side effect? What is the complication of doing a sclerotherapy?
Sir, not audible.
What is the complication of using a sclerotherapy?
Sir, pigmentation.
Very good. And pigmentation, local reactions.
Sir.
Can we stop now, Dr. Lal?
So if you say yes, yes.
Dr. Kanagewal, I think he's not there probably. He's busy.
They all are busy with the IAGS program here, sir, in Chennai. So we are just.
If anyone else wants to ask any question, any other examiners?
No, sir, we can wind up, I think.
Okay.
It's overshot the time also, no? 15 minutes.
Dr. Jairam, you want to ask any question from the...
No, sir. But Prasad, you had a good fortune of facing one of the toughest examiner is Ajay Khanna, sir, and the most learned and most respected examiner is Professor Ajay Khanna. So you are fortunate to face his questions and answer, and you have done really well. Congratulations to you.
Thank you, sir.
Do you want to ask any question from the examiners? Jayaprakash?
No, sir.
Okay. Okay. There's no question. I think we can wind up.
Yes.
Yeah.
Thank you, sir.
Thank you, everyone.
Good night to everyone.
Night,
Good
everyone.
night. Good night.